think is so great about having community-based researchers and peer researchers involved working together is because it brings apart so many different lenses to look at these issues. We work with elders who have so much community and traditional knowledge, and they help provide information insight with that. We have academics who have a clinical biological background, and they bring fascinating insight there.
We find that our peer researchers are really good at helping us to conceptualize the questions properly. They help us in designing the research so it's done in a way that works well with a given population. And when we are collecting the data, they can connect with people in a way that I can't or you can't. They have credibility.
When you have a person with lived experience going out into the communities and sharing this information makes people more comfortable in getting themselves tested and making sure that they know what their status is, and finding out also from the peer researcher on a level that helps them to navigate the system if they were to become positive.
We all contribute in our own unique ways, and I think that is the most important part, because when you're looking at a population or looking at a community, you need diversity. You need people on a team with different lenses, different strengths, and different weaknesses, so we can all learn from each other and build capacity in that way.
Yes, well, there's the principle of two-eyed seeing, which was put forth by Mi'kmaq elder Albert Marshall, which is to see with the strengths of Indigenous ways of knowing from one eye, and to see with the strengths of Western ways of knowing from the other eye, and to use both of those eyes together. And so it's a principle that we're taking advantage of the best that both Western and Indigenous ways of knowing can bring to projects like health research, for patient betterment, for community betterment, and to use both of those eyes together. So it's actually really quite simple. It's taking advantage of the best that we have, not just half of the story.
What made me want to get involved was finding out that in my own community as a peer mentor, there were a lot of people that were ending up very sick with HIV and automatically ending up with full-blown AIDS. So for me, it was important to get involved in the research to find out why this is happening in our communities, and why is this happening. That's why one of the reasons why I wanted to get into research, so that we could find out what the barriers are also in healthcare and bridging the gaps between doctor and patient care.
The history of HIV and the activism that has been a huge part of it all along was always about including people living with HIV. And you know, some people understood that more than others. People living with HIV, or peers, are in the best position to know what that feels like, what sorts of services or programming or program science research that they want, that they need. HIV activism through the 80s and into the 90s really paved the way for what we now call patient-oriented research, because up until then, patients were not engaged by the healthcare system. And so now when we talk about patient rights and all of those things, that came from HIV activism.
It's absolutely rewarding for me to know that when I walk down the street and if I see one of my peers and they say, oh wow, I'm able to do this now, and because of you I've been able to talk, and I can talk freely now about this, and I can speak to my family members, and I can be part of the community and not be afraid because I'm able to share my experience, and I'm not alone, is what the biggest and most rewarding part for me to hear from my peers, is to hear that yes, I'm not alone, and I'm not alone either, and I want to share that, and I want to be able for other people to have that, so that they know that they are not alone.